everyone. I want to introduce you today to Brian Mayrsohn. Dr. Mayrsohn is a pain management doctor at Maywell Health, which is a whole person pain management wellness clinic and pain management clinic. It's a really great integrative multidisciplinary model. So we're lucky to have him today. So welcome, Brian. We're going to talk about headaches today. So if you want to just introduce yourself and then we'll jump right in.
Sure, thank you so much. So as you know, I'm a pain management physician, and what that means is I have a residency in anesthesiology after finishing medical school, and then I do a one-year fellowship in chronic pain management, which covers everything from, neck pain to low back pain to headaches, post-surgical pain, cancer pain, nerve pain, really any type of pain that someone can have, a pain management physician can help with. And like you said, we're whole person pain. So we include nutrition, psychotherapy, and then pain management to bring everything together in the more biopsychosocial approach that's becoming the newest standard of care. So thank you for having me.
Mhm.
And today's topic is headaches. And headaches, as you know, come in a variety of flavors. There are migraines, tension headaches, cluster headaches, cervicogenic headaches, sinus headaches, and then you can even get it a little bit narrower. So first, it's trying to identify what type of headache the person presents with, which comes from the story, right? Taking a step back just to listen to who the person is sitting in front of you. How do their headaches form? Where are the origin? Is there nausea and vomiting associated with the headaches? Is there any light or sound sensitivity with the headaches? So they have to find like a quiet, dark room. Do any other symptoms come with it? Blurry vision, changing in your hearing, tinnitus, ringing of the ears. And then, how do these headaches progress? So from more like the cervicogenic headache, do they start in the neck and work their way up the back of the head? Um, do they have tension in their traps that are radiating, disguising as headaches? So headaches are very nuanced and complex, so it just really requires kind of slowing down and listening to hearing the whole story.
Yeah, I mean, the history is so important, especially when we have something that's kind of an exclusionary diagnosis, right? So when we talk about a diagnosis by exclusion, we want to make sure that we rule all other potential causes of the headache out first, right? So, and then once that's done, let's assume, imaging is clear and, we get a lot of those screens. Differentiating between some of these headaches can be challenging. Is it coming from the neck, like you said, cervicogenic? Is it, migrainous, which are just largely a central nervous system mediated type of headache, whether it's, there's a lot of multifactorial elements there, right? So it's either could be vascular, vasospasms, dilation, could be an electrical issue, could be a serotonin or neurochemical deficiency. So a lot of different ways to manage that subset. But there's a lot of, diagnosing what type of headache it is first helps us with right? Medication management and then injectable management. So let's talk about kind of how you would manage different types of headaches from, tension headaches, cervicogenic, occipital neuralgia, migraine, and how you go about thinking about that from a pain management perspective.
100%. So first I try to figure out, is this something that I am an expert in, or do I need to work with one of my colleagues on on neurology, neurosurgical, internal medicine? So really try to bring in the experts. So migraines, I leave a lot of the prescribing of most of the medications to a neurologist. And if I've identified the patient as having a cervicogenic headache, which is something that I personally treat, um, then trying to figure out, is medication or injection a good approach, or is physical therapy the best approach, or maybe acupuncture or chiropractic manipulation. I really try to use the conservative approach first. So it really depends like where the patient comes to me on their journey. If they've already done years of PT, they've tried chiro and acu, I don't have to send them back to PT to retrial it, but I will try to understand what type of PT they had, what type of exercises did you do, who did you go to. I really try to figure out like what was it the right PT for the right condition. As we know, like not all doctors are created the same. Same with PT in every other field. So we really want to make sure that they were in the right hands so that I don't delay their care further by having them repeat. Um, so let's just say that they had all the right conservative treatment, and now it's time for some sort of medication or injection. Obviously, NSAIDs are always a good first line. Tylenol is very safe as well. Then you can always bump up the NSAIDs to stronger versions, right? So there's actually like four different families of NSAIDs. Advil and Tylenol is just, excuse me, definitely not Tylenol.
Mhm.
Advil, and Aleve, right, is one family, but then you have meloxicam, you have diclofenac, you have celecoxib. These are all different families that have different strengths and potencies. And then you have other headache medications that work more for migraines, like the CGRPs, um, the triptans. There's propanolol. So all these different classes, and trying to figure out which ones would be the right for the right patient.
And
And if
just
they
to jump in,
fail,
right, just to jump
oh
in,
yeah, please.
like some of those classes that you mentioned are to treat the different theories of why migraine occur, right? Like blood pressure, propranolol, you said blood for blood pressure, triptan's more like the neurochemical element. You mentioned CGRP, so like there's different approaches, and some you may have to trial and error. If one doesn't work, you talk to your pain management or your neurologist, and try some others. There's some injectables as well, right? So. Um,
100%. And the interesting thing about propanolol, as you said, for the blood pressure, it's also like a sympatholytic, right? So it cuts out the sympathetic nervous system. A lot of pain is mediated by our sympathetics. So if someone's sympathetic tone or drive is really high, propanolol, even if their blood pressure is normal, I think is actually going to help regulate their sympathetic outflow, which can help decrease pain, which I think is a fascinating concept in and of itself.
mhm.
But you're right. If someone fails those pharmaceuticals, then you could always upgrade to a Botox injection. So Botox of the head, face, neck muscles can contribute to migraines. So people will get Botox every 3 months, and it can bring down the intensity and severity and frequency of the migraines. So it's a very helpful approach.
Yeah, I love that, and I know there's a lot of these thoughts on why make migraines occur, but in medicine sometimes we always want to focus on clinical evidence and why things work and understand why things work, but sometimes we don't always understand why things work, but in the literature we've proved that in fact that they do work. So sometimes we kind of go the other way. It's like, right, we have clinical evidence that something works, and then different researchers will try to promote or work with theories on why that works. So we have evidence that Botox works for migraines. We have evidence that occipital nerve blocks work for migraines, even though we're not sure exactly how, right? We know certain how, we know what happens to the nerve when it's inhibited, but so some of that comes into play too, right? Like, and correct me if I'm wrong there, yeah.
100%. I think now we're getting it also into a fork where there's the clinical evidence that we follow, and then there's the clinical practice that is trained. So in fellowship, you know, unfortunately, not every intervention or medication that's utilized in an intervention has been studied in detail through an RCT, that's the standard of care, to show that this, according to a placebo, is effective, because there's just too much variation in people's approaches. And also, there's just no financing behind these studies, because who wants to invest in a lidocaine study, right? Lidocaine is not this, you know, blockbuster drug that's going to make a company money. So they're not going to support a study that just uses lidocaine. But like, I know that there's a headache protocol that I learned when I was at Cornell that works, that is just lidocaine in a lot of the similar places that Botox gets used, in the face and in this side of in the scalp. And we would repeat that every 2 weeks for 3 sessions. But no one's going to fund that study unless it comes out of like the NIH. Um, so unfortunately, a lot of evidence that could exist in the literature and these RCTs won't exist just
Mhm.
because of a lack of funding mechanism.
Yeah.
So then you have to compare that to, what we do know in theory works. So part of this is the art of medicine.
For sure. Yeah, and we could have a whole nother call about the commercialization of medicine, but we'll pivot back to headaches and we'll talk about
Yes,
so,
yes.
so let's talk about blocks for a second. So we mentioned Botox. What exactly is an occipital nerve block? you can mention, I know sphenopalatine blocks, auricular blocks. What are some of these nerve blocks? What do they do? And how would you use them? In what use cases? Yeah.
Yeah, great question. So the scalp is innervated by various facial nerves and cranial nerves. Um, these nerves can contribute to the contraction of muscles, and these contraction of muscles can cause pain. There's also referred pain from these muscles, and these nerves contribute to the contraction of the muscles and referred pain patterns. So by turning off these nerves that contribute, we're basically resetting the body's nervous system into not being in pain temporarily. And the hope is that when the body resets itself after that nerve block is finished, which only lasts about 8 hours, the person is in a lot less pain. Sometimes we'll mix those nerve blocks with steroids, and that can prolong the effect of that nerve block. But again, the studies are mixed, but there is some evidence to suggest that you don't need to put a steroid in certain nerve blocks and still have the same effect. So I always try to avoid steroid first just to see what the response is. Because if I can get away with a nerve block that is equally as successful as a steroid, I'd rather that be the approach. And if you only get 2 weeks out of it or 4 weeks, you can easily repeat these nerve blocks with no side effects because there's no steroid. If it's just lidocaine, the side effects are essentially zero.
Yeah, that's great. And so some of these are short acting treatments, so some of them could be diagnostic as well as treatment, right? So we know if something works, it can help diagnose kind of what type of headache or if that is an effective treatment as well, right?
Yeah, that's a really good point. So, like, let's say that somebody has occipital neuralgia, which would be a headache in the back of the neck going up to the back of the head. By turning off those nerves, if the pain goes away and it doesn't reproduce their headaches anymore, then yes, absolutely, it can be diagnostic and both therapeutic. And if you can't get the nerve blocks to quote take for more than a couple of days or a few weeks, there are other interventions that you can try that can prolong the effects indefinitely. Like my field does a lot of neuromodulation. So I liken pain doctors to like the hackers of the human body. Just like a computer hacker would hack into a computer system. Well, the brain is a very sophisticated computer system, and we speak the language of the zeros and ones of the brain. So by turning off nerves or scrambling the signals, we can get rid of pain. So there's different neurostimulators that you can place next to the occipital nerve that can turn off the nerve the way that a nerve blocker would, and that can last, years. So there's always, more aggressive approaches that you can take if we can identify the source of pain. But ultimately, like slowing down for a second without jumping into like the neuromodulation, the source of the pain isn't just the occipital nerve, right? Like it could be the sympathetic outflow, it could be the stress of the human that's experiencing that occipital neuralgia. So that's why we really have this whole person approach where, if you have a lot of anxiety, if you're not eating a proper diet, it puts you at risk for these conditions. So I like to use injections and medications to temporize to get people in a good place where they can then go do the healing that they need to do through physical therapy and psychotherapy and changing their diet.
Yeah, I think that's a great place to kind of wrap the video because it's kind of culminates the whole concept of how we treat this, right? It's like we've talked about, medication management, we talked about injectable management, but those are all technically treatments to alleviate symptoms or manage the condition, where sometimes you can actually identify a little bit more the root of the condition. And sometimes if you could identify that perhaps that is more sympathetic or cognitively mediated, there's so many other elements that we can do to treat. So in our next video, you can check us out. We're going to have another chat about that. So but just to wrap up, is there any other thoughts on kind of chatting about headaches before we end here?
Um, I think headaches come in all shapes and sizes, and just really, taking a step back to listen to the story of the person in front of you. And, people are going to come with their own preconceived notions of what their headaches are. Oh, I have these migraines, like not just taking what the patient says as face value and moving quickly through the day, but helping them understand like what the differences are between each of the headache types and how they're presenting is, I think, part of it as well.
Yeah, I love that. So, if you're watching this video, talk to your physical therapist, talk to your pain management specialist, talk to your neurologist, your internal medicine doctor. Don't just say I have a headache. Try to understand and find a good specialist who's going to identify the difference between occipital neuralgia, migraine, tension headaches, cervicogenic headaches, and then potentially even within those subcategories, what are some of your triggers and what potentially could be helpful. So, and then always seek out someone who's going to look into the whole body and the whole person. So, thank you, Dr. Mayrsohn. Again, if you want to check out Dr. Mayrsohn, he's in New York City at Maywell Health, and it's a great resource. So definitely look him up, and his info will be in the notes section of the video as well. So thanks, Brian.
Thank you so much for having me.